Well, thank you. Thank you for the opportunity and the intervention. And I know I've got to do this in less than 8 minutes now, so I'll try. My conflict of interest for this presentation is shown on this slide. So this is where we are in terms of transcatheter valves and imaging. Most of the emphasis has moved from intra-procedural imaging, which is predominantly 2D/3D TEE, to procedure planning. That is where all the excitement is. That is where all the new technology is focused on. There is very few new technologies available once you are in the hybrid OR or in the cath lab. This we know. This is pretty standard practice. CT for planning TAVRs. If CT, contrast CT is not available, 3D TEE is a good alternative. Then we do things like an anatomy-based simulation. Not perfect, but it does help us to understand what happens if you put a valve in, for example, in the mitral position, using a patient-specific CT, and you can understand and measure things. For example, here, the risk of LVOT obstruction, purely based on pre-implant LVOT area, and what happens if you put the valve in the patient CT or the 3D TEE at a pre-specified depth, and of course, the angulation, and measure the so-called neo-LVOT. This is an area I think that is maturing, and I think we know a little bit more, not there yet. We still have to understand the interaction between the valve and the tissue, and not just put it on computational models such as this. But this is an exciting area, especially in the mitral position. One step better than doing it on a computational model using CT would be to print the 3D model of the mitral annulus and the mitral apparatus. This is from Didi Wang. This is a paper that we wrote together with her. It is in press, where you can actually implant the valve in the CT-derived 3D printed model and better understand what happens. The advantage here is you could have 6 prints of this model and implant the valve at different depths and actually measure the LVOT area in the 6 models. You can use different types of valves, for example. All of that is still technology in evolution. But still, procedural planning is where we are as the most important role for an imager who is involved in transcatheter valve interventions. The problem with using 3D printing as it stands right now is we assume that when you put a mitral valve in a mitral position, or your tricuspid in a tricuspid position, in a certain orientation at a certain depth, that it interacts with the tissue as we think it would. But for that, we need a 3D printed model that is made like, or at least mimics, the mechanical properties of the, let us say, the human mitral annulus and the associated anatomy, or the tricuspid. We did this with the aortic valve. We actually made a model using materials that mimics the strain pattern of the human aortic tissue when put under systemic pressures. And then you can put some sensors. You can see in the middle figure A2, you can see some sensors all around the 3D printed tissue mimicking model. And then you can implant a valve and understand what happens to the annulus and the surrounding structures, and predict perhaps better occurrence of PVL, the site of PVL. You can even put this in a flow model and do either ultrasound or MRI and understand what happens to the leaflet mobility. Perhaps some way of predicting future leaflet thrombosis depending on the dynamics. We are still learning. This is preliminary data. It's an exciting avenue. People are looking into other tissue mimicking models for the mitral and the tricuspid position. Computational modeling, however, is not without its advantages. One of the things you can do is use the CT and implant the mitral valve at different depths, at different angles. Not only understand what happens to the anatomical neo-LVOT area, but you can see how the blood flow pattern changes from the apex of the ventricle into the LVOT. And our preliminary data would suggest for any given neo-LVOT area, the pattern of input into the LVOT also determines LVOT obstruction. It is not all anatomy. There is an element of physiology. And to me, physiology is the ultimate determinant of symptoms, not anatomy. You can have a valve area of 2.3, but it's all flow, flow, and flow. And this is an exciting way to understand what happens than just merely measuring LVOT. This is CT computational modeling of flow at different angles. Not to be forgotten, rapidly coming, and I heard Rick mention this today, we got to embrace artificial intelligence. Artificial intelligence to me is not man or machine, it's man and machine. And here is an example of how we would use artificial intelligence for planning structural heart disease. This is CT, real CT from 2 patients with calcific aortic stenosis. And if this is all you had, and you were to develop an artificial algorithm to predict PVL, for example, previously we needed big data. We needed 10,000 CTs. We needed 15,000 CTs. You can have it, but even those will never cover the entirety of the anatomic variations in the aortic root. Now we have things that are called generative adversarial algorithms, which are more complex than neural networks, which will then generate CTs of its own. The computers are so smart, they will generate different varieties of anatomy based on the CT you have provided, infinite varieties from which you can refine your artificial intelligence algorithm to predict PVL. We have looked at this preliminary. This is in a technical journal. Our predictive sensitivity is about 80% now. It has gone from 70 to 80%. We really need to get into the high 95%. If you think this is in the engineering realm, it is not. I'm just reviewing a paper from the French TAVI registry that is using artificial intelligence to predict PVL and what kind of valve should go into that aortic root, purely based on their algorithm of machine learning algorithms. Very exciting. They have about 2,000 patients in this algorithm, which is exciting. What it means is we will not only just be measuring annulus size, but pre-procedural planning imaging will become driven to predict procedural outcomes and even guide the interventionist before they go into the procedure as to what and when to do. Intracardiac echo is the most significant advance I see during the procedure. Standard is 2D, 3D, TEE. Tricuspid valve, I don't think tricuspid clip can be effectively done. If you're a high-volume tricuspid procedure, for grasping tricuspid leaflets, we routinely use 2D intracardiac echo. TEE is not the best way, and it's often very difficult to understand whether you are grasping the leaflets. Here you can see the clip arms coming up to the tricuspid leaflets, clearly see it, and then grabbing, and you can see the leaflets getting taut. And you can even see the grippers coming down. It is 2D eyes, to me, is critical for a tricuspid clip procedure. Not only is it critical for that reason, as you tighten the clip, you can do real-time hemodynamics, both on the mitral side and on the tricuspid side. On the left side here, you can see the clip is partially tightened, and you can see the mean gradient across the tricuspid valve is 4.5. And look at the spectral dropper of the tricuspid regurg on the upside of the baseline. It is still as bright as the forward flow, meaning there is still significant TR. Then you tighten the clip further, color Doppler TR reduces, so does the spectral Doppler TR, but the price you're paying for it is a mean gradient of 6. What ICE allows you to do is to calibrate the amount of tightening of your clip so you can find the best compromise between the reduction of TR and avoiding tricuspid stenosis. This is an exciting technology, can also be applied on the mitral side. We have started to do transeptal ICE for mitral. What does this mean procedurally? Patients don't have to be put to sleep. They can be done under MAC, and they don't have to go under general anesthesia. This will, in many ways, reduce some of the complications associated with anesthesia and elderly patients. Here is the final result, pre and post. You can see on the left side the pre and post. Full hemodynamic assessment plus color Doppler assessment for tricuspid valve. The same thing applies on the mitral side. When we do a mitral clip, at the end of a mitral clip, the most prevalent question is, so what do you think? And I usually turn around and say, what do you want me to say? Because there is absolutely no reliable way of predicting the residual MR after a mitral clip. It is an integrated approach, and oftentimes it's very difficult. There are no perfect indices after a mitral clip. Vena contracta doesn't work, PISA doesn't work, maybe the pulmonary vein flow. The pulmonary vein flow, if it is telling you what you're seeing, it helps. But if it is not telling you what you're seeing, then it doesn't help. One of the approaches that is coming, and this is on the platform, is you can do regurgitant volume and regurgitant fraction, quantitative, pre-procedure on the left side, regurgitant volume of 44, and a regurgitant fraction of nearly 54%. Post-clip, you can see the regurgitant volume and regurgitant fraction. One more index, quantitative index, in addition to the only other quantitative index that is done during a mitral clip procedure, which is the LA pressure change. Together with these two and other semi-quantitative and qualitative procedures, I think this is another important advance during intra-procedural imaging. I haven't talked about fusion imaging. I don't know if it's a serious contender or it is just a pretender in the cath lab. Our experience has been it more gets in the way of doing the procedure than actually helping the procedure. But keep your mind open. It may still be useful, perhaps on the mitral side or on the tricuspid side. Thank you for your attention.